We are here to talk about interventions to support internal regulation using SOFFI. So let's start talking about, if feeding starts with having good internal regulation, what can we do to help with establishing good internal regulation? This is relevant whether you're in the hospital or you're at home. I have over the years been asked to start oral feedings on a baby who's never had any oral feedings before. So the first thing I need to do is ask, well, if you were so unstable you couldn't try before, where are you now in terms of your ability to tolerate that challenge? And so we have interventions that can help babies in hospital as well as at home. Sometimes the interventions look a little different. For instance, if we're going to change the environment in a hospital and the environment at home are different, so our strategies might be different. So our learner outcomes here describe what the just right challenge is related to feeding the premature or medically complex infant, summarize what the feeder should do when homeostasis is lost, and at least one benefit associated with skin-to-skin or kangaroo mother care for mothers and for infants. And there's a study actually that also talks about daddy benefits. List at least one benefit of providing opportunities for non-nutritive sucking to infants within the neonatal intensive care unit or at home. Okay? So, role of co-regulators, we're trying to find this just right challenge. Homeostasis is the ability to maintain internal regulation. So you can wobble a little bit, but you need to have a stable core. So co-regulators, we are looking for subtle signs of dysregulation and responding to those subtle signs so that we don't end up with the obvious signs like physiologic instability. Okay? So we intervene if we need to, and that is based on this idea of a just right challenge. So when we are looking at a just right challenge, we need to just remember that we want to allow some tolerable stress while the infant is able to maintain internal regulation and avoid toxic stress. So that's really what the just right challenge is meant to remind you of. Okay? The way you can use your algorithm, you can use it to reflect on what you did after you're done with the feeding, or to stop and think about what are you going to do when you go in to work with the baby. Okay? I also use it when I'm teaching staff, when I'm working as and precepting some of our new NICU nurses. When I'm teaching families, I use it to remind myself that I need to cover all of the topics. Now, I don't hand the algorithm to my families because it's overwhelming. And remember, they are in black and white thinking. So we need to remember to provide information in a way that is helpful for them. Okay? But the algorithm is helpful in making sure that we all think about what is stability. If I think, oh yeah, this baby is stable, and one of my colleagues thinks, oh, there's no way he's stable. Well, if we're both stopping and asking the question about stability, now we have an opportunity to have a dialogue. So what is stable? And in our unit, what are acceptable parameters in terms of feeding on nasal CPAP or high flow or any of the others? Okay? So the just right challenge is different for every infant, and it's based in part on their baseline stability, but it also changes throughout the day. So if I had a really good sleep, I will probably have a little more energy to deal with the challenge of eating. If I had a terrible day and was passed around, never got to sleep at all, people were taking 100 pictures, and all of that is really important for families, but it also can detract some of my energy that I would love to have for feeding. So we want to just think about, this is challenging, would be a just right challenge. This is aversive, is not a just right challenge. We've gone too far. Okay? So if you start to see problems in the physiologic system, as we've talked about, then the challenge is too great. So you have to be able to reflect back if you see that, what did you miss? Okay, and I can tell you, I have videos of myself missing the earlier signals. So it still happens to pretty much all of us. So I think about cross-system. What's happening in their attention, their behavioral state, their motor, so that I can gather extra clues, okay? So first and foremost, infants are always needing to be considered within the context of the environment of their family. And the World Health Organization even specifically reminds those of us working with children and infants that we need to always be working with the family, because infants should be considered as part of the environment of their family. Okay? Infants' abilities are a dynamic interaction between their health conditions, the personal developmental factors, which we've talked about, and environmental factors. So I feel like we have gotten those pieces down in this series. So any of our functioning, physical, social, mental functioning, is always within the context of our developmental capabilities and of our environments. So we're going to start off by sharing with you a report that has been published. It was published actually in 2011. The executive summary was published in 2021, last year in October. This is a report of the first consensus conference on standards, competencies, and best practices for infant and family-centered developmental care in the intensive care unit. Okay, so not just neonatal intensive care, but we're actually saying you could use this in PICUs, in NICUs, in cardiac care units, any intensive care unit. So this is where professionals and parents came together to create some consensus around what are developmentally supportive care practices. Okay? So this was not specific around how do we help babies to eat. This was about how do we embed developmental care practices into everything we do in the hospital. Okay? So the content is actually available on the web. It's a website sponsored by University of Notre Dame, and you have the website link here. I encourage you to go to this link and to just take a look at all of the things in there. I was part of the consensus committee. I specifically did work on some of the feeding standards as well. We also had input from around the world, different physicians and parents who gave us their input as well. Okay, but the reason why I encourage you to go to the website is, number one, there's a lot more detail on the website. Number two, everything that we're going to be talking about has evidence behind these recommendations, and the evidence you can find on the website. We're specifically going to give that to you. And these are going to be constantly evolving, and so that's another reason why. We're going to be talking specifically about the feeding standards and how those support the interventions that we're going to be talking about. But there are standards on sleep and arousal, on positioning and handling, on stress for babies and for parents, on pain management. So there's 6 different areas that we covered in terms of our standards and our recommendations. And so it's a lovely free resource for people, okay? So typically, again, we have two different algorithms, and one is for babies who are just learning, and one is more for early intervention. But really, for the most part, they are similar, at least, because they are going to help us think about, first, what can we do to help with internal regulation, okay? So regulation provides the core to help babies tolerate environmental demands and to learn to integrate new skills. Okay? So first we have to start with helping the physical core be stable. This means that we are thinking about the medical side of things as our starting point. So respiratory, Are we needing to be thinking about providing oxygen during feedings? Or is it okay to try feeding this baby if they're on nasal CPAP? If not, what would be our recommendation? We want to think about the motor system, and are we helping babies to develop the best motor system prior even to eating? So postural supports, making sure babies are having some flexion and not developing retraction. Okay? We can think about things like swaddling and how that might be supporting the baby to be more stable or confident and comfortable. We can think about the environments can help with facilitating rest, and everybody does better when we have good rest. Okay? And tolerating or interacting with babies where they are tolerating what we're doing. Okay? If a baby is not improving, you have to go back to what do you know about the baby's physical health, and is there potentially something that is impeding their progress, is making progress either very slow or is keeping them from making progress. So this is your hint as a reminder. If you're watching how a baby is progressing and they're not actually progressing, you want to keep stopping and asking, what's going on? Why are they not progressing? Okay? I think sometimes we as therapists anyway, try to jump to another intervention technique. And while that certainly might be appropriate, I think first we need to ask the question, is there something I'm missing? Okay? So we have interventions that can help with homeostasis when babies are in bed or when they're being held or when they're sucking and enjoying that process of non-nutritive sucking. Okay? So we can start by thinking about the environment and providing support so that the baby has enough energy to try the feeding. Okay? Sometimes we inadvertently take energy away from a baby instead of allowing the baby to conserve as much energy as possible. So you see, we start with readying the materials and the environment. And the next question then is, how stable are they when I haven't done anything yet? Is this a good time to try something as challenging as feeding? And as long as they're stable, then we can start asking, are they showing readiness behaviors? And if so, I can bring them to my arms and I can see if I can help them really solidify an alert state by using non-nutritive sucking. And there are several ways we can provide non-nutritive sucking. If along the way the baby is showing instability, we all need to stop. We need to stop and help the baby first, okay? After we stop and help the baby, we decide, well, should we try again, or should we just call it a day and finish with a tube? If you're working with the tiny little babies, if you're working with babies who are at home or who are a little bit older, oftentimes you don't have a feeding tube, then the recommendation is to stabilize, get them back to baseline, and try again. So one of the standards that we have is mothers or others should be supported to be the primary feeders of their baby. And we put M/others because certainly most of the babies, it will be mother, but lots of daddies are going to be the primary feeder as well. And we have lots of different ways that families are made up these days. And so we wanted to try and be sort of neutral on that. We know parents are crucial to the preterm infant. We talked already about the sensory environment that parents bring to babies. Early separation from parents adversely impacts neurodevelopment. We have research for years that have shown us this. A lot of infant mental health research has gone into looking at what happens to the development of the infant when we separate them from parents. So it affects their autonomic system, their neuroendocrine system, their immune system, and long-term consequences of separation include poorer neurocognitive abilities and poor emotional processing. Okay? So we want to keep parents and babies together. The next thing we need to do is we want to have the parent be the primary feeder of the baby, so we need to provide parent education. Okay? And one of my strong recommendations is make sure the parent has the information necessary to assess the infant during feedings and to intervene to minimize problems, because that's how they're going to build confidence, which means they have to have the information before they need it. And that's one of my big take-home messages. We have to be educating families. And if you're in early intervention, you're typically doing both at the same time, right? You will already be working with a baby, trying to help them with eating, and at the same time trying to do as much education as possible. If you're in a neonatal intensive care unit or a hospital setting, especially if you're working with babies who are born and there is a period of time before they're allowed to eat, you have a golden opportunity to provide parent education well before the parent needs the information. So break down what parents need to learn. And that is actually another way you can use the algorithm. What I have done is I am working with, I haven't finished, working with a design team to create a parent education program. Now, the one that I originally created had 27 different handouts for families. Some were about just normal development, and the first 5 were about organizing babies, their internal regulation, then pre-feeding and feeding skills, and we finished with some handouts on different interventions if we needed to use those handouts, okay? So this is just an example of one of the handouts, and so we try to make the language parent-friendly. That is one thing I'm still working on, but you see I am covering some of the same topics that you get. But I have one page that the parent may get on one day and a different page on another day. So we're trying to break this down into manageable bites. Part of the feedback that I've gotten from the hospitals that I work in, where I started piloting it, is there's a lot of papers. And so then we started to create booklets, and we're trying to figure out how do we break down the booklet so it's not one big booklet. And so that's why I said we're still playing around with some of this. I'm still making sure that the language is more parent-friendly than it is right now. At some point, it will be a new thing that I launch. I started with something very simple, and so can you. So you could hand write out things to practice if you're in the home. So this week, the parent practice is to look at breathing and, practice recognizing when it's comfortable or not. In the hospital setting, I round with my physicians every week, and we talk about the babies, and ideally all of the families are there when we're doing that, because we have individual rooms. So I can have a conversation with the family and all of the medical team, and it's still private. So I used to have stickers, and I would physically write information for the family. And I was trying to teach important concepts prior to the parent needing that information. So things like breathing and watching breathing or understanding behaviors. Pretty much it always had information about holding skin to skin and about providing human milk if possible. But here we are giving parents something specific to do, and we can practice with them. And that's another piece of it, okay? Is if you're talking about what babies are doing to communicate, then have the parent watch their baby and identify, look, your baby has some nice roundedness in her shoulders. That's a really good sign. And her eyes are open and she's looking at you. That's another engagement behavior that tells us that she's ready to engage with you. Okay? So you really want to keep up with ideas of how do you help parents be parents, especially in hospital settings. In homes, clearly, they're generally more frequently the people providing all of the cares. But this is a study of parents where they did a randomized trial. So some parents got education through a structured program, and others it was kind of hit and miss. And with this structured education program, what they were trying to do was encourage parents to participate in all of the daily cares. So changing diapers, holding during tube feedings, positioning the baby, how do we nest the baby, all of these different things, taking temperatures. These are things that parents can do. They don't take a whole lot of expertise, okay? And what they found was by having parents with the babies all the time, or as much as possible, so they were really increasing that interaction, they had a significant decrease in the physiologic instability and in feeding intolerances in the babies. So that is a wonderful way of helping babies get ready for the challenge of oral feeding. We also saw a trend in using more breast milk at the time of discharge. Okay? Kangaroo mother care, holding skin to skin. And you'll see in the literature either of those terms, skin to skin or kangaroo mother care, KMC. We have years of data that tell us it's a wonderful thing. And it's wonderful not only for baby and parent outcomes, but it's also wonderful for doing things like supporting that bonding and attachment that will have long-term effects as well. Reduces postpartum depression and helps infants with better physiologic stability, which is necessary for eating well. Helps to establish breastfeeding, and moms who kangaroo tend to breastfeed longer as well. Has positive impact on infant development and parent-infant interactions. And it also helps parents be more sensitive to infant behaviors. So of course, if we are trying to help parents be there for their babies and understand the behaviors of their babies, this can help with that as well. So we see early kangaroo mother care is a way that we can, again, reduce the number of days to full oral feedings. In this study, it went from 12.5 down to 9 days, reduced feeding intolerance, and improved discharge weight. A Z-score is just a standardized percentile, if that kind of threw you off when you saw that. We also see brain maturation with kangarooing. So in this study, preterm infants being held skin to skin 1.5 hours a day, 4 days a week for 8 weeks, brain activity improved. It showed more complexity and better development of behavioral states. It helps with oxytocin release. Oxytocin is our happy hormone. It also helps with breast milk production. And so here they were looking at oxytocin in mother, in father, and in baby when baby was being held skin to skin. And you can measure that through saliva. They also were looking at cortisol, which is your adrenaline hormone. And they found across the board, moms, dads, and babies had more happy hormones when they were holding skin to skin. So I tell families all the time, this is a very stressful place. And the more that we can help you have calming influences, the better. One of the best ways to get calmer influences is when you are holding your baby skin to skin. We also saw that infants had a decrease in their cortisol levels, so their fight or flight adrenaline system was basically being dampened when they were being held skin to skin. Parents who had more oxytocin also showed more sensitivity to their baby behaviors. Okay? So kangarooing versus skin to skin, really, I think of them as very similar. Some people have said kangarooing is holding your baby 100% of the time. That's not how most people think about it, even in Denmark, where they have a lot of supports for families to be there all the time. Most aimed to initiate skin to skin contact the very first time parents came into the neonatal intensive care unit, and on average about 2/3 of the units were seeing parents holding 2 to 4 hours, and in a third it was up to 8 hours, which is delightful. So kangaroo mother care leads to improved breastfeeding outcomes, both improved direct breastfeeding, also exclusive human milk diets. Remember, exclusive breastfeeding with the World Health Organization just means 100% human milk, but it also can improve the use of donor milk in certain cases as well. So these are some of your outcomes, and you have both in hospital as well as post-discharge. OR, if you remember, is an odds ratio. So for instance, for moms who kangarooed, who held their babies skin to skin, they had more milk production during hospitalization, less feeding intolerance, better weight gain, better length gain at the time of discharge, and at 6 months of age, they were almost 14 times more likely, that's a huge number, almost 14 times more likely to be exclusively breastfeeding compared to babies who didn't have skin to skin. Okay? And the neurobehavioral scores were higher as well. So even if you can't get human milk directly from mom, donor milk has some benefits that formula does not. Now it also has some challenges that we'll talk about in just a moment. So it can help with the development of the gut microbiome, and probably all of us have now heard about this. It's all of the flora, the different bacteria that live in our gut that are so important for us to fight off infection. Formula-fed babies have a microbiome that's very different. The best is what you're getting from mom. Second best would be donor milk, even though it's pasteurized. Okay? It still has some benefits. One of the challenges for donor milk, in addition to getting it and the cost of getting it, which is a significant barrier in many places, is that because it's often donated by moms of older babies, it doesn't have always the kind of composition that a preterm baby needs. So a mom who has a preterm baby, her milk is different right from the very beginning than a mom who has a term baby. Breasts are amazing. They just seem to know all kinds of things that you wouldn't think they would know, but they do. So what happens is if you are getting donor milk, oftentimes it's from an older, from a mom who delivered much further earlier, and they also pool many of the moms together. And so sometimes you see weight gain isn't as good on donor milk. Okay? So the other barrier, like I said, is it's very expensive. Okay? So human milk has lots of different benefits. Colostrum, so that early excretion from the breast, that is gold. And we have more and more information that helps us to understand that helping babies get that early colostrum, even if it's just kind of going into their mouth with a syringe, can help them with fighting off infections. There's a decrease in sepsis, increase in your infection fighting abilities, and lower levels of pro-inflammatory cytokines. So lots of really, really good benefits from colostrum from a medical standpoint, but also from a taste connection standpoint. Another standard that we have is environments should be supportive of an attuned feeding for both the infant and the feeder. Adults get distracted by things that are happening in the environment. Babies do too. And sometimes the challenge is more for the parent and sometimes it's more for the baby. And so again, we have lots of different ways to address this. What we're going to do first is talk about an environment that is similar to a NICU or hospital care setting, and then we're going to talk about environments in homes. So the environment can be challenging for the infant, the family, and the staff. So the first thing we need to do is think about, if parents are going to be the primary feeders, we need to have a space for the parent to be with their baby. And I am so lucky now because in my hospital, we have single family rooms. So parents can come and be with their baby, and we have a lot of ability to modify the environment so that it can really be good for that baby and that family. I started in a hospital, well, my hospital that I'm still in, had a big room that had all of the babies in it. We would have 30 to 40 babies in one big room. Okay, that's a lot of babies in one big room. The noise level was much higher, but it also was crowded and busy and distracting. And so that was a lot more challenging for parents when they would come in. Okay, so your ideal is, how can we decrease some of the sounds? How can we limit some of the activity? If you're in a big ballroom with lots and lots of babies, maybe the best you can do is have the parent facing away from the aisle so that they're not looking out across the room at all of the other babies. Maybe you can put up a screen or pull the hanging screen from the ceiling around so that at least visually you're limiting some of the distractions. Dimming the lighting for some babies can be really helpful, and in some cases actually critical. I have a video that you're going to see in a few minutes of a baby who really cannot handle bright lights. And certainly we would need to make some adjustments to that. So you really want to think about, how do we limit distractions when parents are trying to feed their babies? I have done some consultation with various hospital systems around the world, and some places parents are still not allowed to come in all the time. They may be able to come in for an hour a day, and that was before COVID even. So, thinking about what are the restrictions for having parents there, and how can you kind of start chipping away at them? I did a consultation in a room that was so noisy that when I came in, within about 3 minutes, I thought I was going to lose it. Okay? And not only was it super loud, but there were no chairs for anybody to sit in. And I said, well, how do you sit and feed babies? And they said, oh, well, as a staff, we just go and drag a chair over. And I said, what do you think is telling your parents if they come in and there's no chair welcoming them to sit down? So it really is stopping and thinking about, if you don't have families coming in to be with your babies, is it in part because you may not have a welcoming environment where they feel like it's important for them to be, and they're not in your way? The other thing, obviously, is we have families who end up having to go back to work, or they don't have transportation. We had a situation recently where a baby was born at 27 weeks, and Mom and dad had recently immigrated from another country, and they had 3 little children. So I think like 18 months, a 2.5 and a 3.5-year-old child, okay? And mom didn't drive. And it's COVID, and it's flu season. So how is this mom supposed to be with us and her baby when she has children that can't come in with her because of flu season and COVID, and dad has to drive her, and dad is working 2 jobs? I mean, it is not easy to, have families there all the time, sometimes because of the situation with the family. And we try to say we can have somebody here to watch your older children, but the parents were really uncomfortable with that, in part because there's a very different environment in the United States than where they came from, okay? But the environment affects feeding, and not just for babies, but also for us as feeders. This is a study where they asked staff and parents, what helps you to focus on the feeding and not be distracted by everything else? And a lot of what they talked about is what I've already talked about. Feeling like they belong, that there is space for them, that this is a homey environment where it feels like they should be feeding their baby. And then you see an experience of a door or a shield against people entering so that parents can have privacy. That helps them to focus within on the baby and the feeding, and regulate socialization. Because as human beings, especially as adults, if somebody sticks their head in, you're going to look up and talk to them. And so even something as simple as putting up a little sign saying, hey, give me a little break here. This is a video of a baby where the visual, the lighting in the big room is clearly too much for her. And what I'm going to ask you to do when I play the video is watch how she is showing you several engagement cues when we have shielded her eyes. And then I want you to see what happens when we take our hand away, and what are her behaviors, and then what happens when we shield her eyes. Okay? This is an opportunity to look for things like arching, color change, stopping breathing, yawning, all of those things. Okay? And her eyes are open even though it's dark, because clearly our hand is over her eyes. She's fairly calm and just kind of gently sucking. So this would be your baseline. And when we take our hand away, she stops breathing, she's arching, she's turning red, looking away, yawning. She's clearly in distress. We're giving her time to see, can she make this adjustment? And as soon as we provide shade, she comes right back to being organized. Okay? This is an example of a baby who needs the environment to include dimmed lighting. Okay? Not every baby is going to need that. But we have to start by thinking about, what does this baby need in terms of the environment? Okay? The environment in the home has different kinds of challenges. So we need to think about, yes, some babies still need some adjustment to lights or noise or stimulation. Think about the distractions are very different in the home. We have televisions in most homes, and telephones, and other children running around. We have pets that you won't find in neonatal intensive care units. There are people who come over and want to hold the baby or talk to the baby or talk to mom when the baby is being fed. I will tell you, one of the times that I cringed was some of my videos I actually gathered when I was doing my postdoc 2-year training, and I did a research study. And part of that research study, I was filming babies from the day that they went home, and then at term, at 2 months, and at 4 months. And so some of the videos that you're seeing actually came from that. I was in the neonatal intensive care unit of a different hospital, so I was collecting from across the Denver metro area, actually. And so I was videotaping a parent who was trying to feed her baby, and while she was trying to feed her baby, early intervention coordinator had come in and was trying to do an intake with the parent. That's really challenging, hey? And I thought, oh, we should actually probably have a conversation about letting parents focus on feeding and not trying to do paperwork when the parent is trying to feed the baby. So different kinds of environmental influences. What can we do? Make sure that the parent starts thinking about turning the television off or putting their phone away, or at least putting it on silent. You know, sitting in a room and keeping the dog and the cat out. With siblings, sometimes it's as simple as having a box of special toys or a coloring book and crayons that only come out when you're trying to feed the baby. So, you know, sitting down with families and trying to come up with what are some of the things that distract you. And again, when parents are in black and white thinking, oftentimes what I do is I actually sit down and I write out the list, and then I write out what they need to do before they start feeding. So they now have kind of a checklist of, okay, I did adjust the lighting and I did turn off the TV. Okay? Some families are families where you start with the TV, you turn it on in the morning, and you turn it off when you go to bed. And so it becomes just kind of background noise. So sometimes having an actual checklist helps. Okay? You want to think about supporting the infant's sleep and arousal. And again, this is an area where we have some recommendations that are posted on the website for developmentally supportive care. Ideally, we feed once the infant starts to demonstrate hunger signals, so feeding on demand. Okay? We want to think about what kind of state stability does this baby have, and do they have transitions up and down the continuum, or do they jump from sleeping to screaming to eating and then back to sleeping? Hard to learn about your world if you're not ever calm and quiet. Think about holding babies before they start orally feeding, before a gavage feeding, during a gavage feeding. Clearly, in most NICU settings, you do not have time to sit and hold babies who are getting tube feedings for the entire feeding. But can you try to hold them once a shift for maybe the first 5 or 10 minutes? You know, really kind of changing the thinking. A lot of times people think, well, I need to save my physical time as a staff member to work with babies who are starting oral feeding. But we can help babies be more ready by starting to train the baby to wake up even when they're just getting tube feedings. Talk or read to the baby to help with alerting. It's one of the challenges of single family rooms. Although there's only one study that showed babies didn't do as well in single family rooms. And in that particular study, they identified if parents are not coming in to see the baby for whatever reason, and the baby is always in a room by themselves, that is not very helpful for later development. There's a lovely study that shows the more words a baby hears, starting already by 32 weeks, the better their language development is later. And so we want to start to encourage alerting, especially around feeding times. And then to help babies have more energy for feeding, we need to protect their sleep. Okay? Support calming activities, and we have a number of different things that are being tried to help with calming for babies. Modify the environment includes increasing stimulation for some babies. So I always say, whatever I need to do to help a baby be successful is what I'm going to do. And for some babies, that has meant that they're in a room with all the lights off. They have the curtain pulled, there's no sound. Someone basically sneaks in, picks them up, feeds them, puts them back down and leaves. Okay? Typically, these are babies who are really struggling with withdrawal symptoms. So we can help them eat by decreasing all of the stimulation, minimal stimulation. But that's not how the world works. And so if we do that to help them be successful, the next step is to start consciously modifying the environment to help them build the skills to be able to keep eating with slightly more stimulation. So that's equally important. Taking away stimulation and helping babies modulate their reactions to stimulation are equally important. Okay? So thinking about this demanding behavior and feeding babies when they are starting to demand. We have research that shows that this can help babies to transition to full oral feedings more easily. And they have been done with healthy preterm babies as well as babies with bronchopulmonary dysplasia. When you're practicing based on baby behaviors, it also means that you stop when they want to stop, okay? And the benefit now is that you're allowing the baby to practice when they're waking up, and that actually reinforces that they should start waking up when they feel hungry. So you are literally reinforcing the demand, understanding learning, okay? And if you think about it, oftentimes when you have somebody who says cue-based feeding doesn't work, okay? And usually they're not that direct about it. But I still have, on occasion, people will say, well, she has more energy when we only feed her, every other feeding. And so they start to limit the times that the baby is allowed to practice, even if the baby is waking up and showing that they want to eat. Remember that multiple small volumes might actually be more than a large volume. You want to be thinking about across a day. Okay? If you're only feeding them and giving them a rest every other feeding, you're limiting the amount of practice that they can do. So even if they take smaller volumes, if you do it more frequently, you may actually see that the total is larger. And so it's always helping people to think about letting the baby practice when they show alerting behaviors helps them not only with achieving volume, but also recognizing what their job is when they feel hungry. Okay? Their job is to wake up. So we have a variety of different people trying different things. We're still looking at this. This is a study out of 2022, and they call it a semi-cue-based feeding, which I think is actually very accurate. Because if you keep a baby on a schedule and allow them to practice on a feeding schedule, whenever they're waking up, that's actually semi-cue-based. A true cue-based feeding program would allow a baby to eat off schedule. Okay? So they actually recognize that. This is a study out of Iran. And they had a 3-step intervention. They were using a behavioral cue-based feeding approach. Okay? So they call that a BCBO. They had a NIDCAP certified professional who oversaw this approach. So NIDCAP is a acronym. It stands for Newborn Individualized Developmental Care and Assessment Program. And it is a program that was developed by the same people who developed the Synactive organization. So it is a very rigorous behavioral observation program that's actually used in I don't know how many countries. It's literally worldwide. So they kind of stepped up opportunities to try feedings, starting with one every 12 hours for 3 days, and then they allowed 2 behavioral-based feeding opportunities. So that means that if the baby was awake, they were allowed, but they were only allowed to do it twice in a 12-hour shift. So that could be up to 4. Okay? And then they were able to allow the baby to eat on their demand. What they found by being a little bit stepwise in reaching Q-based or semi-Q-based feedings is that they decreased oxygen desaturations by doing that. And other events like apneic and bradycardic events. Weight gain actually was better from the time that they started this protocol up to 21 days. There were no significant differences in the frequency of apnea. The events were bradycardia, sorry about that. And the time to achieve full oral feedings was not significantly different. So it's a way of looking at quality and improving quality and skill, not designed to get babies out of the hospital sooner. Okay, so this is a retrospective review of people implementing Q-based feedings. There are a number of different strategies when it comes to Q-based feedings, and what they find is that when you implement Q-based feedings, typically the number of days to achieve full oral feedings decreases by 7 days. Length of stay can also be decreased by 4.5 days, and parent involvement is increased as well. So lots of lovely benefits for Q-based feedings. At some point, though, we have to recognize that there is a lower limit to our length of stay and our gestational age at full oral feedings. And that's where I sort of struggle, is when people say things like, well, you know, we should be able to get babies home at 34 weeks or 35 weeks. That is a mistake. And it's usually based on the fact that if one baby can do it, all babies can do it. And we know that's not true. So this is a study on Q-based feedings for late-born preterm babies. And you see the number of days to achieve decreased by 6.5 days, length of stay decreased by 2.5 days, and involvement in feeding increased as well. We also have the sync protocol, eating in sync, related to breastfeeding and nasal CPAP. Eating while you're on nasal CPAP. This is a different way of using that same protocol. So this was not designed to see if we can feed babies on nasal CPAP. This was just saying, hey, they developed a protocol for progressing in practice in oral feeding, so we're going to try that with all of our babies. And they found that weight gain was improved in the group who were using the sync protocol that had a slow progression towards oral feeding. There were no significant differences in when babies transitioned to oral feeding or in their length of hospitalization. So when we think about intervals for feedings and how often should we be feeding babies, we don't have good information to answer that question. Brand new newborn babies have a tummy that probably means they should be fed every hour. And a lot of brand new newborn babies want to eat quite frequently. Okay? But as you eat, your tummy starts to grow and you can tolerate larger volumes. We don't have any real good studies on preterm baby tummies. Okay? So there is now starting to have some question. Is every 3 hour the right interval? Maybe every 2 hour is a better option for babies. And they did not find significant differences in necrotizing enterocolitis or in reaching full feedings in general. Okay? What they did find is infants with a birth weight of less than 1,000 grams reached full enteral feeding, so they had better feeding tolerance, slower when they were on the longer interval 3-hour feedings. They seemed to do better with 2-hour feedings if they were under 1,000 grams. And so like many things in feeding, there are lots of caveats. May work for term, but not preterm. May be okay if you're under 1,000, but not so good if you're over 1,000. Okay? We do know that larger volumes and longer intervals may be contributing to some of the GI issues that we are having. If I'm not eating as often, I tend to overeat, and the more my tummy is full, the more likely I am to start having spilling out. So we want to be thinking about stomach volumes as a variable when you're looking at their comfort during feedings or their endurance to take full volumes in for optimal growth. So let me give you a little caveat, or a little story, I guess I should say. I was working with a baby who had Prader-Willi. And she was this wonderful, amazing baby, lovely family, was able to breastfeed actually fairly well, was transferring about 40 to 45 milliliters at breast, not doing as well with bottle feedings, not that surprising, but generally was eating right around 45 milliliters. And she needed more like 55 milliliters, 55 to 60 every feeding. And no matter what we did, she just seemed to be volume limited. We just couldn't get her up to that level where we could then pull the tube and send her home. And so after about a week of just trying all kinds of different things, we flipped the question. And I sat down with a dietitian and I said, you know, if she can eat 45 milliliters, maybe that's her tummy volume. Maybe she only has a tummy that can handle 45, maybe 50 milliliters. So if she was eating 45 milliliters every time, how many feedings would she need to have? Instead of saying she needs 55 for 8 feedings, what if we said 55 milliliters or 50 milliliters or even 45 milliliters is what she can take? How many feedings would she need so that she could still get the whole volume in that she needs for growth? And it wasn't that big of a difference. She needed 10 feedings instead of 8. Now that may seem like a lot, but in a 24-hour day, that's roughly 2.5 hours between feedings instead of 3. Now, yes, in a very busy nursery, very hard to keep track. You know, people are on 3-hour schedules, and all of a sudden you have a baby who's on a 2.5-hour schedule. But the parents were there, and the parents said, we'll be happy to feed her every 2.5 hours. And when we changed the rules, she was able to meet her target. Okay? The other thing to remember about babies with Prader-Willi is they often are pretty fatigued. They don't show the same readiness behaviors as we look for. So they don't really wake up, demand, put their hands in their mouth. They're much more kind of sluggish when they're waking up. And so what we said is whether she looks like she's sleepy or not, now that she's a term baby, we need to be picking her up. We expect more from term babies. And so that combination of the two really helped her to go home. Now, there are other things that people are trying, infant massage, music therapy, those kinds of things. So let's briefly kind of talk about that. Infant massage may be beneficial, but most of the published articles actually have what's considered a high risk of bias. In other words, if I'm a massage therapist and I want to show that massage therapy helps and I do the study, that would be a potential bias, right? I'm trying to find evidence for what I'm doing. So that's not ideal, although I always say from a clinical standpoint, doesn't mean that it's not good research. All right. Most of the infant studies have been done on term infants and can show some really nice benefits. If you're older, okay, you might see improved growth, increased sleeping, reduced time spent fussing and crying, and better digestion. So it's one of the things that I often recommend when I'm working with babies in the home. I think infant massage is delightful for babies in the home. When you look at the evidence to support it in the neonatal intensive care unit, then it gets a little tricky, and it actually is not strongly recommended in our developmental care standards. Okay? There are some issues around, you know, touch and the ability to tolerate touch and that sort of thing. If it's actual massage. Now, touch therapy is different. Okay? Touch doesn't involve the friction that you can get with massage. Music therapy, this is another one where it's like, oh, you have to be careful about what you mean by music therapy. Okay? This is a systematic review of 13 different trials. They have over 1,000 babies across these different trials. What they found was that it can help, or change at least, heart rate and respiratory rate, and maybe oral feeding volumes, but in 2 studies, babies in the music group actually showed higher stress than babies who were not getting the music. Maternal anxiety can be improved. So I think music is really lovely for adults and for staff, but maybe not for babies. It's a bit out there in terms of the question. I think, again, it has to do with what you mean by music therapy. So is it recorded music off of a tape recorder? Is it live music? Is it a guitar? Is it, are you playing rock music? Are you playing classical music? Does it make a difference? These variations, I think, will help us to understand music therapy a little bit better. Here they had 26 different outcomes that they found that people are trying to look at as, whether this is a beneficial thing or not. So live music led to better sleep in 3 out of the 4 studies that looked at sleep. Heart rate was improved in 2 out of the 4 studies, and feeding and sucking had evidence in 1 study, 1 out of, I think it was 22. So that doesn't mean that everybody was looking at feeding. Okay? Recorded music is not quite as supported by the evidence, okay? But you see feeding and sucking outcomes seem to be improved in 2 of the studies, heart rate in 2 out of 6 studies. This I thought was interesting because here they specifically were looking at classical music, and music is music for most babies. We as adults have preferences as to what kind of music, but if you're looking at some of the benefits of music, we often are actually looking at things like the rhythm that you're hearing, and they didn't find any improvement in time to regain birth weight or time to reach full oral feedings for babies who were listening to classical music. All of that said, we have wonderful information that shows parents singing to their babies, parents talking to their babies is so wonderful. Vocalizations may be as important as skin-to-skin contact for the neuroendocrine regulation and social bonding. So this means parents in live situations talking to their babies and singing to their babies. It can increase preterm infants' emotional stability and autonomic stability, and it can reduce maternal anxiety. So rather than thinking, oh, well, we'll just turn on music, I strongly encourage parents to be with their baby, to talk to their baby, to sing to their baby. We have a book library that we started with the express purpose of getting parents to read to their baby and to sing to their baby. So for me, music therapy would be trying to get parents to sing to their babies, more so than having someone playing, music or turning on music in the room, okay? So let's talk about positioning and handling and how that's gonna help or make things harder. So when we're looking at the algorithm, at some point we get to, yes, the baby's showing feeding readiness behaviors, we're gonna pick the baby up and bring them to our lap and offer them non-nutritive sucking opportunities. But how we do that will make a difference, okay? So we need to think about if we're not supporting babies with positioning or when we're moving them and we're handling them, that can be detracting from the energy that they have. And many babies don't have a whole lot of energy to give to the feeding. We want to think about supporting them with swaddling instead of moving them in space without any boundaries to help them. Or use your body So instead of picking babies up and holding them away from you, you want to pick babies up, bring them to your body, and then move in space with them holding up against your body. Okay, and then prepare for the feeding, as we've talked about. So I have a little video that I have pulled off the internet. It's one of the few that is not of one of my babies that I've worked with. So I'm going to start off by saying I do not know where this came from or who these people are. Okay, people always are saying, oh, I think it's a nurse, or I think it's a therapist, and it really doesn't matter. We've all had bad days. So the person in the sweater is a professional. That we know, okay? This family is coming in for the very first feeding opportunity. So dad is actually videotaping everything. And I don't know about you, but when parents are videotaping me, I sometimes am distracted by that, and I may make mistakes that I don't normally do. So I'm gonna give this person that benefit, because with all of that said, there are so many opportunities to have done things differently in this video. So this is a baby, and hopefully you'll be able to hear. We've been kind of playing around with the sound back here behind the scenes. Dad obviously is going to be much louder because he is right next to the camera that he's holding. But mom is sitting down, dad is videotaping, and the person in the sweater is the person who's there to help them with their very first feeding. And at the very beginning, because you may not hear this because we're playing around with, you know, how loud the sound should be, the dad is going to say she's 45 days old. Okay, so that tells you how old this baby is. We don't know how young she was when she was born, but when you see her, you're going to see she's pretty little. And so my guess is she was, you know, one of those 25 to 28 week kind of range when she was born. Okay, so I'm going to ask you to try and listen to what the parents are saying. So I'm not going to be talking, and then I'll pause it, and then we'll talk a little bit, and then I'll start it again. Okay, so here we go.
It's me, little Brett. So this is going to be Leah's first attempt at a bottle. Day 45, I think, right?
Oh yeah, 49. just hanging out.
She looks like a little Yoda.
She does. Got no fuzzy head.
Okay, we're good, thank you. Oh, we attached that first thing. Oh!
She took her CPAP off.
Here she comes, Mom.
How am I holding her right now?
However you want to. We need to clip. There we go. This will not stay closed. Alright, I'm going to have to grab some tape.
Oh yeah, she's wound up.
Oh, you get
That's that 202 is her heart rate.
Dad, do you know where the blanket warmer is?
I have no idea.
Okay. Let me go get some warm blankets, okay?
Okay, so let's take a moment and kind of think about what we've just seen. Okay, and this is an opportunity. If you've been working with babies, you probably are already putting together all kinds of things of, okay, how do we do that differently? Hey, we haven't even started feeding, but think about, do you think she has as much energy as she did when she was laying in bed all snuggled up? Probably not. So let me just kind of hit some of the high points. First of all, we take her out and we hold a very tiny naked baby out in the cold for an extended period of time because we haven't gotten our things ready. Okay? So instead of swaddling this baby so she could retain some heat and didn't feel like she was flying around in space, we didn't stop and think about that. Okay, so that's why in the algorithm we say get everything ready before you start thinking about moving babies. Okay, the person wearing the sweater is, not prepared, pulling all of the things out. The other thing that you may or may not have heard, and you will hear Dad talking about it in this next section, is that this baby is on nasal CPAP, so she needs respiratory mechanical support when she's in her bed. But what you'll notice is she's out of her bed and she has no oxygen support. She's not on nasal CPAP or on oxygen. And if you work in neonatal intensive care units, you are already paying attention to her monitor. Her monitor is pretty much beeping the entire video. What happens is they turn it off, and then after a period of time it comes back on and they keep turning it off. So all they're doing is ignoring the message that this baby is not respiratory stable. Okay? And when Dad panned up to the monitor and he said, wow, she's wound up. She is in fight or flight. So her heart rate is 202, which is high, and her saturations are 88, which is low. Okay, so we are not starting off with good baseline. Now, one of the nice things is because the person in the sweater had to go away to get some more materials, this baby actually has a moment of rest to kind of, not jump directly into the feeding. So that's a whole lot of stuff to think about. Let's think about the parents. They're having very different experiences right now. Dad is like, woohoo, here we go. And Mom looks terrified. She holds this baby and she's doing her best. You see that her maternal instincts are absolutely right on. So she's trying to figure out, how do I help her? Clearly this baby's distressed. But if this parent is feeling like this just holding her baby, we're going to ask this parent to feed her baby, but she doesn't appear to have the information that's going to help this feeding go well. Okay? So these are some of the things that went into my thinking about writing out. We actually have to stop and think about all of the things that we do kind of without thinking when we are professionals. Okay? We need to be more mindful of these things. And then finally, notice the baby's disengagement behaviors. So physiologic instability, not great color, arms and legs constantly coming out, kind of, more external in her movements until Mom is bringing her back. All right, we haven't even started the feeding yet. So let's see how that goes. And I'm going to start the video just so that we can watch what happens when the baby starts eating.
Oh, that right eye is really puffy from the CPAP, huh?
I know.
Wow. Look at that
It's
eye.
really
See how
bulgy.
puffy that is? That's crazy. And that's what the CPAP does. Whatever is the downside on her head, it kind of makes her puffy now and then. Not always, though. It's very exciting.
I bet it is. There we go. All right.
Okay.
All right, Dad, you have the bottle.
I have the bottle.
All right.
Oh, she's wide awake now.
Good.
So let's see if Leah wants to do a new trick today.
All right, there's 10 cc's in here.
Okay.
We just want to try her. If she has some interest, that's great. And if she doesn't, that's okay too. We'll put it in the tube. We want to have her kind of side lying as we feed.
Okay.
We don't want to force the nipple into her mouth.
Right.
But we can kind of rub here to see if she has any interest. She's going to smell and taste the milk.
Are you sitting okay and good for right?
Let her kind of get a little.
What do you think about that? What do you think about that?
Hey, Leah.
Just take that all in. This is new. What do you think about this?
You know, it's going to be a little bit more difficult for her to try to feed because she does have the tube,
Yeah.
you know, in her mouth. But right now, we don't want. I mean, we don't want to take the tube out.
Right.
She's still on her bubble, so. Okay, hold that in there.
What do you think about this?
She's suckling on it.
Yeah, she sure is.
Oh, look at her go. That's awesome.
Oh, goodness, she's doing great.
Is this good?
Okay, so I don't know about you, but for me that's a bit stressful. Okay, what you want to think about is the person said all the right things. Okay, the person in the sweater said, we're gonna, put her on her side, but clearly they didn't. We're not gonna, push the bottle in her mouth, and then they did. Okay, they're completely ignoring the monitor. They keep saying, hey, this is a problem. She's not breathing well. Her color is not very good. And when she starts eating, she moves into reflexive sucking. Dad thinks, wow, this is great. Look at her eat. And the coach makes a mistake and she says, wow, this is great. And right after she says that, she then has to go to the monitor to turn it off again because now the baby's actually in pretty significant distress. So the monitor changed to, hey, this baby's not getting enough oxygen, to this is a problem and you need to do something. But all of that is being ignored. And all we're thinking about is, look, she's sucking. She's sucking and swallowing, she stops breathing, which is why her monitor goes into kind of overdrive, okay? So I know a lot of you are working in home settings, and for you, you're watching this and going, wow, well, this isn't the kind of baby that I see. Number one, many of you have babies on your caseload where this is their early experience. Okay, so that's one thing. I like to use this video for a whole lot of reasons, as you can see. Yes, this baby is teeny tiny, but the younger they are, the more exaggerated their disengagement behaviors are. So it's easier from a teaching standpoint. But I also want you to stop and think. You probably, if you're working in the home, have parents who are not paying attention to things like their baby gulping, or turning colors, or saying, I don't want to do this, right? And part of why is because we make mistakes and we say things like, wow, she's doing great, when clearly she's not, okay? This is more of a safety issue than anything. And so we always need to kind of stop and think about the babies that you're working with and the families that you're working with oftentimes have different experiences with different people. Even if you're at the very beginning and working with babies in the neonatal intensive care unit, you may have a staff member who is missing and all they're thinking about is volume. Okay? You want to stop and think, how are you going to help the parents see these behaviors in their baby, especially if someone else on your team has told them she's doing great and has not helped them understand the stress instability or the engagement disengagement. One of the most challenging things for us is to undo some of that learning, okay? She isn't breathing well, but you know what? In the nursery, her monitor was going off, she was desaturating. Clearly wasn't a big deal because all we did was turn off the monitor. We didn't stop and give her extra support from a breathing standpoint. Now, like I said, the person who's helping them says all the right things. So clearly this is a person who understands how to support babies and for whatever reason didn't use that knowledge very well, okay? Okay, so let's think about now some oral inputs. Caregiving activities should consider baby's response to the input, especially around the face and the mouth, and we want to avoid non-critical care oral experiences if possible when they're aversive. Okay? So we have lots of ways of doing touch inputs. This is a lovely study where what they said is babies do better when they get touch and when they get held. So they did either hand swaddling, so the person feeding put their hand on the baby's shoulder or on the upper thigh around the diaper area, okay? Or being held when they're getting gavaged for about 5 minutes, or I'm sorry, during the gavage plus then 5 minutes. A minimum of half of the time was their protocol. And then when they started some oral feedings, if they needed to do gavage feedings, they would hold them during the gavage feedings. And they found that babies with this protocol indeed were touched more and held more as well. There weren't any differences in oral feeding milestones though, which was kind of depressing to me, but certainly there were no negatives. And so even just human touch may be one way that we can provide some supports. Babies have lots of negative experiences. So regardless of age or their stability or their medical condition, we should think about how do we provide some positive experiences, okay? Most routine hospital experiences that have to be done are unpleasant. They may cause pain or at a minimum discomfort. Oral care, suctioning, all of those kinds of things. And those, like I said, are mostly unavoidable. So we need to think about, well, how do we counterbalance those negative things with some positive things? And we always have to think positive means in the eyes of the baby, not in you. So when I start thinking about providing positive oral experiences, my number one goal is watch the baby. If the baby is crying or showing any signs of instability, they're telling you it's not positive for them. Okay? So babies may enjoy sucking on their ET tube and do not need you to be giving them other ways of sucking, okay, as one example. So we need to be thinking about how do we support the babies who are less ready for any kind of oral experiences, how they go through their enteral feedings, how many times do we have to start and stop enteral feeding, can affect how they acquire oral feeding skills. The more enteral feedings are a challenge, the more likely oral feedings will be a challenge. And as we've talked about, rate and volume of what they're getting in their tummy both can affect comfort and growth. Generally, slower enteral feedings improve comfort. But if we start to go slower, we need to think about nutrition. Okay? Babies show better behaviors and better tolerance when they get continuous drip feedings versus a bolus. A bolus would mean that you give them a set volume and then you stop and you give them a break. Okay, that's really what a bolus feeding means. And this one basically said, you know, babies do better when they are being continuously drip fed, at least up to about 32 weeks. Okay? The problem with continuous drip feedings is that you often are losing some nutrition. So you see that fat is one of the nutrients that you lose during the feeding process when you are using continuous drip feedings. And that is certainly especially true with human milk when it's delivered. And so that's part of why people are constantly trying to get babies onto a bolus feeding, because optimal nutrition is critical. And we have very clear data, better growth in the hospital, better outcomes after the hospital. So these are just some of the recommendations for providing optimal growth. I always have questions about, okay, the video you just saw, the baby had an oral gastric tube, and is that common? In my hospital, the answer to that is no. And if a baby is on nasal CPAP, we often have an oral tube down to take the air out that goes into their tummy instead of into their lungs with CPAP. So oral gavage tubes generally are in if that's the case, but we change to nasogastric tubes. Here what you see is that actually they looked at, is oral or nasal better? Is there one or the other? Here they actually found worse outcomes for babies who had nasogastric tube placement, but I want you to come back to this was at 33 weeks. So trying to eat with an oral feeding tube is very different than how do you tolerate oral versus nasogastric tubes when you're 100% gavage fed, okay? So smells and tastes are other biologically expected inputs for babies. So consider using the smells of mom, and especially of mom's breast milk. So breast pads as part of her clothing. Have her put in, a bandana into her bra as she's walking around, so that smell is being collected. Skin to skin holding. We have smells in our skin as well, and so that can be helpful. Positive experiences can be more than just smells and tastes, although we definitely want to focus on biologically expected smells and tastes. So when you think about smells and tastes during gavage feedings, you want to think about there actually are data that support using smells and tastes. You see improved head circumference and length at 36 weeks post-menstrual age in a group of babies who received smells and tastes during gavage feeding. It didn't change feeding outcomes, and they reached full oral feedings at around 38.5 weeks. Okay? When it comes to oral pharyngeal administration of mom's own milk, as we've talked about, that can be helpful, and it can help with immune properties. Fighting off infection is what I'm trying to think of. Okay? Colostrum in the mouth is associated with shorter recovery of birth weight and shorter time to full enteral feedings. And here you have a lower incidence of adverse health and outcomes, including late onset sepsis, and in infants under 29 weeks, or 29 to under 31 weeks, they had reached full enteral feedings earlier when they were getting oral pharyngeal colostrum experiences. Okay? So you have multiple studies. This has become a big area of research recently as well. Okay? This is a study where they said our babies are breastfed babies, and so we think we can teach babies about breastfeeding and going to the breast by using the odor of the mother's breast milk. So half of the babies, when they were getting gavaged in the incubator, they had a smell of the mother on a pad that was soaked with her breast milk. Okay? And then when the feeding was done, they took away the smell. Okay? And what they found is babies actually transitioned more quickly to full breastfeeding when they were able to do that. And there were no negatives in terms of that study. Okay? So the other benefit of using mother's own milk early is it increases the odds that the mother's milk production will be sustained, basically up through at least discharge and hopefully past discharge. Okay? So as we've talked about, mother's own milk is better than donor milk, especially when it comes to improved weight gain. Okay, other ways that we can support. Let's just talk about the non-nutritive sucking really quickly. Non-nutritive sucking, the largest body of evidence supports sucking for comfort on your fingers, on your mother, on a pacifier has benefits. And I'm not going to read through all of them, but you see there are lots of benefits, including decreasing length of stay and supporting better bottle feeding performance. Okay? So we want to think about helping babies start to associate my tummy says that I'm hungry, someone picks me up, I'm moving my mouth and my tummy's getting full. Even if I'm not able to orally eat, this is an opportunity for me to be making those associations. So if they're able to do that, can we start adding in smells and tastes? That would be delightful. And we have studies that show, even compared to things like oral stimulation, babies have better weight gain when we use something as simple as non-nutritive sucking. Okay? So somebody's already asked about sucking during breastfeeding and whether that's okay or not. Is it for pleasure or is it for transfer of volume? This is a study where they asked the question, if we allow babies to go to breast, is that going to be a problem? And so they had mothers pump, just hand pump, not using a hospital grade pump, their breast for 5 to 10 minutes before putting the baby to breast. And the baby was allowed to go to breast for 3 times a day. And they said, well, we didn't have any positives or negatives. And so they felt like it was a safe practice to allow babies to go up to the breast. So pacifiers, as well as other oral things, are important for us to be thinking about. And someone asked about using the kind of pacifier that you might be thinking will be a similar shape to what the bottle is that you're going to be using if they're bottle feeding babies. Breastfeeding babies, there is no pacifier that is like a breast. It just isn't, because it doesn't feel the same. Okay? They have small ones. You might need to start with a smaller one and work your way up. For older babies, think about lots of different teething objects. You know, there are all kinds of things out there, and they don't all have to be therapy teething objects. We have some great options that actually have been part of oral stimulation programs. Babies might love to start doing hand to mouth with some of those. But there also are a whole variety of things that you can just find for typically developing babies, because we know babies are oral explorers. Okay? And the biggest question is, does it interfere with breastfeeding? And you have several studies that show it does not. In fact, this study shows that babies who were sucking on a pacifier had the best latch scores, which is a measure of breastfeeding ability. What you want to think about is anytime you're offering oral experiences, especially if you're using pacifiers, that is an opportunity to assess more than just, is the baby enjoying this process? You are adding in the ability to look at strength and coordination and rhythm of sucking, and does the baby have suction? We're talking about supports for infants before they were being fed. Now we're going to start to be thinking about those babies who are a bit struggling with getting from here to there. So they're able to have a rhythmic suck on a non-nutritive object like a pacifier, or sucking on a finger. And every time you try to offer feeding, they seem to struggle. They cough, they choke, they're not sure how to do things, and no matter what you do, they get stuck there. So let's talk just a little bit about those babies. We have sort of a middle ground there. We can be mimicking all of the normal feeding experiences to the best of their ability. So if they're able at least to be given tastes, then we would want to be continuing to build the sensory abilities by offering taste on the pacifier. I shared with you a study about putting babies to a mother's empty breast. And so you want to be thinking about what can you do to get them closer and closer to being able to handle some fluid in their mouth. Being held as much as we can, especially during feedings, putting them on a similar schedule as a baby their age. And so we talked about the interval is probably 2 to 3 hours, not 4 to 5, which in some cases we have fallen into. And then interacting with them as much as we can as well would be another thing to do. So we have talked about empty breasts and pacifiers, also their fingers, the parents' fingers, and trying to connect flavor with those experiences. I do have here as a caution that we want to be thinking about those tastes are designed to help the baby learn about the fluid that they're going to be eating. And so we want to be giving them the same fluid that they will be getting orally at some point. Sometimes people say, well, he likes breast milk and he doesn't like this formula. If he's going to be on that formula for a long period of time, it's important for us to be teaching him how to accept both the breast milk and the formula. And so we always want to keep coming back to why is it that we're offering non-nutritive sucking? It has 2 reasons. The main reason is just to help a baby get organized. The secondary reason would be to be pairing it with tastes. We also can be pairing it with smells, and we saw that that can be an effective strategy as well. So if you have a baby who is very restricted on any kind of flow, if the pulmonologist or the physician have said he's not allowed to eat, maybe he was aspirating, what could we be thinking about? Well, even those babies, I talked to the pulmonologist about whether it's okay for the baby to even just get 1 drop on a pacifier of the fluid that he is needing to learn how to eat. And usually as long as the baby is not aspirating their own saliva, then the physician usually says, that's fine, I just don't want volume. So for these babies, and there's not a lot of them, but for these babies that are struggling to go from taste on a pacifier to actually accepting a breast or a bottle, we want to think about how do we go very small incremental steps from non-nutritive up to nutritive. And there are a couple of different options for you that I have listed out here. Number 1, you could purchase something called a Binky trainer, and I've given you a telephone number where you could call for this product, and it is the picture that you see. So basically here there is a small plunger attached to a very small tube that has been threaded through a pacifier. So now as the baby starts sucking on a pacifier, the fluid inside the plunger you could deliver using either pushing fluid out of it. If you aren't pushing, they might even be getting a tiny little taste just sucking on their pacifier and pulling the plunger down for themselves. That would be providing resistance, so it would even slow the flow more. There are some specialty bottles that have been created specifically to help babies go from non-nutritive to nutritive sucking in very small incremental steps. And I'm going to share with you one of those in the very next module. So the other thing that you could do is something that I started doing with babies that I have worked with, simply because both the Binky trainer and the specialty bottles cost money, and we don't always have them in stock. And so for me, I kept running into trying to find a workaround. And as I was finding a different way of providing taste in a rhythmic manner, I started to develop my own protocol. And I use this protocol about twice a year, maybe. Most babies are able to make this transition with a lot of support from us, but they're able to successfully go from non-nutritive to nutritive sucking. About twice a year, I have a baby who gets stuck. And no matter what we try, they are starting to freak out, is the best way I would explain it. So if you try to give them a bottle, they may start to suck and swallow, then they just stop, they move into obligatory, and they don't know what to do. And so we want to get them out of practicing the wrong thing, which is just stop and do nothing. And so I have developed this protocol where I put 1 to 3 milliliters in a 3 milliliter syringe, and then I give the baby a bottle, nipple, or teat just to start sucking on. And it would be a very slow flow. But really what I'm doing is I'm going to be dropping 1 drop of fluid from the syringe into the bottle nipple and wait for the infant to suck that 1 drop into their mouth. When you're trying to do this, you really want to keep only 1 to 3 drops of fluid in the bottle nipple while the infant is sucking. Okay, just 1 drop at a time is your ideal. You're not putting fluid in a bottle and giving the baby the bottle, even if it's 5 milliliters or 10 milliliters in the bottle. What you're doing is you're actually being very careful about delivering tiny, tiny amounts through the bottle nipple itself. So the nipple goes into the baby's mouth, but it's not attached to a bottle. Okay? Your goal is to just simply drip 1 drip in. Now, a couple of benefits here. You are actually able to see the fluid inside the bottle nipple or the bottle teat inside the baby's mouth without the bottle itself attached to it. It's pretty easy actually to visualize. What you will notice typically is that you'll drop 1 drop in, the baby will be sucking, thinking that it's non-nutritive. They will get a tiny taste and they will stop. They will look really scared, anxious, any of those kinds of words, although babies don't really have necessarily those emotions, if you will. But they have learned that flavor usually causes them to, stop breathing. The key is nothing bad happens because it's such a tiny, tiny amount. And so when the fluid doesn't keep dripping in their mouth, they take a breath, they breathe a couple more breaths, and then they have 1 tiny little tentative suck. And once again, they get a very small amount and nothing bad happens. And your job is to basically keep 1 drop ahead of them in this process, okay? So that the bottle nipple doesn't end up empty, but it also doesn't fill up. And part of the reason why is because when there is a lot of fluid in the bottle, gravity is actually going to push that fluid out of the bottle. So you will have an external force, if you will. What I find is that babies where I'm being very careful using this protocol, they learn to build some confidence in themselves as well as in the bottle. And the goal here is to help them understand if you start sucking and there's smell and taste available, you are going to get fluid. If you stop sucking, the fluid stops. So it's a very consistent practice. With the Binky trainer where I'm pushing fluid, or when I was dropping fluid into the corner of their mouth, that's not as consistent because sometimes when they're sucking, they don't get any fluid. And sometimes when they're sucking, I decide to push a fluid into their mouth, or I decide to drop fluid into the side of their mouth. That's inconsistent. So I'm trying to teach them, if there's smell and taste and you have something in your mouth, when you start sucking, you will get taste. When you stop sucking, the taste stops as well. So that's one of the big benefits, is that you're able to restrict the flow, visualize exactly what's going on. The other thing that you're going to see is that you have a very immediate feedback as to whether the baby is building confidence. Because in the beginning, they may take one small suck and then stop. They may stop for 20, 30 seconds before they try another suck. When you're doing this protocol, what you will see is over time, the baby builds some confidence, and those pauses between sucks will get shorter, and you may even start to see 1 or 2 sucks coming together, 2 to 3 sucks, where they're establishing sucking bursts, a whole actual burst. So that's the benefit of this. I usually will start with a 3 milliliter syringe, work my way up to a 5 milliliter syringe, using the same system. Okay? So it doesn't have a feeding tube attached to it. I'm literally just dropping fluid into the bottle teat itself. Okay? Your goal is try not to let the nipple empty fully. Now, one of the biggest concerns that people bring up is, well, isn't the baby going to be swallowing air? And what I will tell you is, yes, the baby will be swallowing air, and that's okay. First of all, you minimize the amount of air the baby swallows by keeping the drop or 2 in the nipple at all times. Okay, so your goal is to, every time he's taking some out, you're replacing it with another drop. The other thing that you will start to see is that you will be going through your 1 milliliter or 3 milliliters more quickly as the baby is starting to build confidence. So I generally am using this strategy up until about 5 milliliters. And once they're rhythmically taking about 5 milliliters, then I make that transition back to actually putting fluid in the bottle and offering them the tastes in that way. So I just finished using this with a little boy who, no matter what we did, would look like he really wanted to eat. He was sucking vigorously on his pacifier, loved his pacifier, but the minute he tasted milk from a bottle, he didn't know what to do. And he kept having heart rate decelerations and stopping breathing and dropping his saturations. So we went back to this middle ground, and slowly he built up some confidence, and then we were able to start transitioning him to a bottle. Meanwhile, he was actually doing pretty well with breastfeeding, and I was actually saying, well, he could go home just breastfeeding, but the parents were really anxious about that. Even though he was breastfeeding well and transferring good volumes, the father said, well, but you know, my wife works and I work, so we're going to have to get him to take a bottle. And so we kind of did this little mini step. Okay? So the goal is that as much as possible, we want to maintain some oral practice. And the oral practice should have as many parts of eating as possible as part of it. So these are some of our key takeaways for this module. We have really spent a lot of time talking about feeding begins with internal regulation, and we can support the development of internal regulation to improve the infant's ability to tolerate the challenge of feeding. And remember, that is a big feeding. Biologically expected inputs are preferred and include things like the parents and just being held skin to skin, smells and tastes, especially of human milk. If the baby will be eating formula, you want to be giving smells and tastes of the formula. And then it also includes self-regulatory oral and facial exploration. So helping babies to explore their own faces, put their hands in their mouth. You can drop some of the fluid on their fingers and help them to associate hand-to-mouth activities.